Can we have Dr. Sharadini Vyas? That's the last talk. She'll be talking to us. She's going to be our next host faculty next year. AIOC for corneal pathologies and Femto assisted lamellar keratoplasty.
So, a very good morning to all of you, and I'll try to finish as fast as possible and try to cover two topics in 6 minutes. Otherwise, I'll talk on one topic. So, the first topic is about femto-assisted lamellar keratoplasty, and as we know that the lamellar grafts that we have available today is about the anterior lamellar graft for the anterior and mid-stromal scars, the deep anterior lamellar graft, and then you have different endothelial scars. What we will be focusing about is the anterior and mid-stromal opacities, the treatment in the form of anterior lamellar keratoplasty. So when we started the anterior lamellar, we had the manual dissections by which we approximately used to calculate the depth and do the dissection, and then came the era of microkeratome assisted anterior lamellar graft. And now we have the limitations of the anterior lamellar graft with microkeratome also is the precision of the depth was plus minus 25 microns, and the interface was not as smooth as we wanted it to be, and therefore it was limiting factor for the visual recovery in these patients. So with the femtosecond laser, the advantage is it is highly reproducible, and the graft host junction makes it so precise that the grafts are more stable. It needs, in the superficial graft, needs either no sutures or minimal sutures for the deeper graft, and therefore the healing is fast and the visual recovery is better. Now, the main important thing in femto anterior lamellar keratoplasty is that the pre-planning is very important, because we have to use lot of different types of cuts for different depth and size, and we have to make a combination of the cut. So the planning of the treatment is very important, but for the superficial we have to just give two cuts. One is the two interior side cuts, and one is a full lamellar cut. So this is the pre-operative photograph of a patient who had central and mid-peripheral. Actually, mid-peripheral should be the limit. Here the scar is going little to the periphery, so we prefer that if it is limited to mid-stromal, it is better. But if it is superficial, we can definitely go ahead. On the right side, you can see the OCT photograph, and here is the post-operative picture of this patient. This is the sutureless, because the thickness was just 170 micron. And what I'll do is I'll just go for the, this is not my own video. So this is the deep lamellar cut, which will separate the depth of the focus, and at the end we will give this side lamellar cut. These are the side lamellar cuts, and then you remove the suction. And the most important thing, see how easy it is to remove the graft. See, you just have to stretch out and it has come. Now this is the recipient eye. Same procedure is done in the recipient eye, and then you just remove the graft and see. This is the side cut. It's so easy. It's so easy, and see the smoothness of the surface. That is the biggest advantage. And now from the donor, you just put it on the recipient cornea, and then you are done. Sutures are required only if you have to go for the deeper dissections and the thickness which is more than 200 or 250 microns. So it is very good therapeutic modality we have available, but the restricting factor is the cost and the availability of the infrastructures. And then going to my second talk also, I like to finish as early as possible, and that is about the AIOC in the corneal pathologies. So this is the normal AIOC, and there are n number of indications wherein we can do the anterior segment OCT for different corneal and anterior segment pathologies. I will not go into the detail of the list. We will just see some of the clinical cases. This is a patient who had post-RK ectasia. Now see, if you see the central OCT, that is absolutely normal, but he had a paracentral ectasia, if you see here. So that is how AIOC is helpful. This patient was then fitted with scleral contact lens, where again the OCT was very helpful. This is a post-LASIK ectasia, again to localize the cone. If you have only anterior surface topography available, it will localize the apex of the cone and the thinnest area. This is again the same patient. Then this is a patient who had a corneal foreign body. So AIOCT is very helpful in knowing the depth of the foreign body. This actually is another patient. This patient is a pediatric patient who had undergone TRAB. So if you see the anterior segment here, there was significant PAS. So this was not the proper site for the another AGV wall, and that's why it is helpful, the OCT is helpful in localizing that which part will be the best area for the AGV. And this is the corneal foreign body, and here it was a full thickness. You know that when you remove the foreign body, you have to be ready for TGBCL. This is a picture of DSEC, where you can see a very smooth graft which is well attached. This is the anterior lamellar keratoplasty, where again you can see the depth of the graft and attachment. This is the fitting of the scleral contact lenses, and it is helpful in knowing the vault and the edges of the picture. Now this is again a foreign body patient, and then we removed the foreign body, did the topography, and did a topography guided PRK, and that makes the anterior surface much better. And the most important indication is DMD. If you see it here, this is the DMD, and this is the post injection. You see the air bubble which is attaching the Descemet's membrane, and this is the 1 month photograph. And then you have a number of indications like keratoconus in different stages, the OSSN, where you want to know the involvement, extension of the OSSN inside the anterior chamber. This is very helpful. So in conclusion, it is not a mandatory tool that is required, but it is very valuable if you have it available for all the anterior segment pathologies. Thank you very much.
Thank you, ma'am. Thank you for helping us. We apologize to the next for slightly getting into your time, sir. Sorry.